Yes, thank you very much. I brought a very interesting case, and I think we can have a nice academic discussion about this case without knowing how to treat it exactly at the end of the session. But I think it's very important to gather the available biological information about these patients and to look what can we do at the point where we are. So this is a 54-year-old postmenopausal patient who presents with a large lump of the left upper quadrant. It's about 5 cm, and clinical, you would have said, is a CT3 cancer. She has no family of breast or ovarian cancer. She's in a very good performance status. She has no relevant comorbidity. And you see here the mammographies from this patient with the lump in the upper left quadrant and a very dense breast. So I ask you, who would have done an MR in this case? Hands up. Yes. So next slides. We did an ultrasound examination in this patient showing smaller tumors, and T2 tumor, and we did a jet needle biopsy on the tumor, and we had some suspicious lymph nodes in the axilla with these lobular lymph nodes with eccentric hypertrophy, and we did a jet needle biopsy to this axilla too, because we wanted to know about the tumor stage. And on the right side, we had a little lesion and architectural distortion on this side. And I show you the corresponding MR, which shows a monofocal tumor, a T2 tumor, smaller than the clinical appearance, and another lesion on the right side, which has been classified as a MR Biret's 4 lesion of the right breast. So after this pre-therapeutic diagnosis, we do have lots of variables about this case. We do have the postmenopause status, the age, CT2, N+ tumor, and according to the ultrasound, it was an N1 tumor, and we had no evidence of metastasis. We had a histology of invasive lobular cancer, which fits very well with the diagnostic imaging in this stage, and a G2 breast cancer. Immunohistochemistry shows a hormone-sensitive disease with ER 90%, PR 60%, and a Ki67 of 14%, which is a low proliferating tumor according to the standards of our pathological laboratory. And on the right side, we had atypical ductal hyperplasia in a biopsy from the right breast guided by MR. So now at this point of the discussion with the patient, we asked the patient whether she wants to have chemotherapy, because with chemotherapy, we would have done a downstaging of this tumor. We probably would have had less surgery to the breast and to the axilla, but this breast could be operated with a breast-conserving surgery, but you needed reduction mastopexia if you don't downstage this tumor. On the other side, from conventional immunohistochemistry, you know that this tumor looks like a luminal A tumor. And our Danish colleagues showed from their retrospective analysis of a prospective trial that in luminal A tumors, chemotherapy sensitivity is low, and this patient may probably not benefit from chemotherapy. So we were in a mess how to treat this patient from our variables that we had at that point, though we had a lot of information about this patient. So my first question to you is, would this patient be a candidate? Is this patient a high-risk candidate for chemotherapy and for extended adjuvant endocrine treatment? Yes or no? Only on the basis of a positive lymph node and a large tumor. Please vote. Oh, you are quick. Yes, no, that's what I previewed, and I think the panel on Saturday will decide, as you decided, you don't know. So my next question would be, would you consider testing, because you need more information, and I think most of the audience will vote for yes, because really you are divided in this situation. Please vote as quickly as you can. Okay, there's a large majority who feels like I felt, you don't know how to treat this patient and you would like to have more information. So what kind of information can we have for this tumor? You can treat this tumor with endocrine therapy, and you can treat this tumor with chemotherapy. And you know, and that's what Professor Gligorov already said, you have a good prognostic information by baseline criteria, but now you want to know what kind of therapy is going to work in this patient. And I would like to advise you to read the PRETHERAPEUTIC trial, which has been published in San Antonio 2017, to know more about endocrine responsiveness of this large invasive lobular cancer. We know that invasive lobular cancer may be less chemoresponsive than ductal carcinomas, and we have to look whether this tumor is endocrine sensitive. That makes the decision much easier if this endocrine treatment works very well. You may have much more chances to omit chemotherapy. And in the PRETHERAPEUTIC trial, patients had a baseline Ki67 and they had a sequential Ki67 after 3 weeks of endocrine treatment. And the post-therapeutic Ki67 is correlates highly with the endocrine responsiveness of the tumor. If there's this early drop in Ki67, there is a good prognosis for the patient. That is a very simple approach for this patient, for example, who had this MR-guided biopsy. She had not surgery after 2 weeks. She had a time of diagnosis and staging of about 2.5 weeks, and we gave endocrine treatment, an aromatase inhibitor in this patient, to know about endocrine responsiveness in this tumor. On the other hand, you want to know how chemosensitive is this tumor, and we do have for node-positive data for recurrence score from the SWOG trial, which are shown in the right side of the slide. And you see that there's a very good correlation between chemotherapy responsiveness and recurrence score, with only those patients benefiting from chemotherapy who have a recurrence score more than 30 in this population. That's what we integrated in our ADAPT trial, which you will see in 2021 probably. This is one of the cornerstones of evaluating Oncotype DX. We did first the window in this trial for endocrine responsiveness, and patients with higher or intermediate risk situation which did not respond to endocrine therapy were randomized to chemotherapy question. And that is a very good clinical approach which can be already realized today. Now, my next question would be, you do have a very popular tumor, but most data for Oncotype DX testing are for ductal carcinomas. Would that change anything in your decision to do Oncotype DX testing, knowing that you have a lobular cancer or papillary cancer or anything else? Please vote. Oh, that's very quick. Yes, no. Good question. So let me show you the data. These are the recurrence scores according to histological subtypes, and you see a very large amount of cases which has been evaluated. About 600,000 patients have been evaluated, and you see in all these patients the a very similar distribution of oncotype of recurrence score risk groups. And in these patients, high risk always is, in every subtype, is much more risky than low risk. The hazard ratios are about 2. So you see that it's expressed in lobular cancer. You see that lobular cancer has a bit better prognosis than expected for ductal carcinoma, and the range of high risk is lower in lobular cancers. You find this in the literature, and I think this is our clinical feeling too. So how do these patients do with chemotherapy? There's retrospective analysis from the SEER database, and I think it's very preliminary, but the data are for about 7,000 patients, and you don't see in these lobular cancers any special chemotherapy effect. So at the end of this discussion, we have a situation where we know, okay, we do have a tumor which is endocrine responsive probably, but which has low chemotherapy responsiveness, and we did our Oncotype DX testing. And this testing showed you a recurrence score of 21, but at the same time, which is not very high, but at the same time, since she is nodally positive, you do have a distant recurrence risk at 9 years of 18%. But chemotherapy benefit is only about 1%, according to a limited amount of data. The message of this is you have a tumor which is dangerous to the patient, but you can't treat it with chemotherapy. That is the main message for this tumor, I think. And so the patient, we discussed this result with the patient, and she said, no, I don't want to take chemotherapy. That's why we did primary surgery to this patient with the following results. In the pathological report, we found a PT2 tumor, which was multifocal. We didn't expect that from our diagnostic management. We had a PN1A situation with 2 involved lymph nodes from 12, a G2 tumor, and we had a drop of Ki67 to 10% and a recurrence score of 21. On the right side, surprisingly, we had a little papillary carcinoma of 3 millimeters with a good immunohistochemistry, which was treated by radiotherapy to the breast only. So let's go on for the systemic treatment of this patient. You already saw for node-positive disease recurrence score data, Professor Weiner already showed to you, that we have some data with large numbers of patients in the registries, in the SEER registry and in the CLARLET registry, all showing that in the group of the PN1 lymph nodes, that Oncotype DX testing is really prognostic. It's a good prognosticator. It's stable all over these thousands of patients. I think this is a very important message, though we don't have the prospective data from Eric Sponder. But we have some prospective data which are coming from Plan B. Plan B is a trial conducted by my own study group, by the West German study group, as the ADAPT trial too. And it primarily asked the chemotherapy question, TC versus AT regimen. But we, at the time when we started the trial, this was in 2009, we already felt that there was a large proportion of patients who would be overtreated with this situation. And in fact, after having the results of TAILOR-X, we have about 35% of this population which has been overtreated according to the TAILOR-X data now. But in the beginning of this trial, we were very conservative. We said, okay, if the patient has a recurrence score less than 12, she doesn't need chemotherapy, even if she has involved lymph nodes. But only 1 to 3 involved lymph nodes, because differences also in the Plan B trial between N0 and N1 are not significant. But there's a large gap from N1 to N2. Their tumor burden really matters. So what will we have as overall survival or distant disease-free survival in these patients who often have not been treated with chemotherapy is excellent. And it looks very much like the TAILOR-X data for node-negative disease, but there's a limited number of patients integrated to Plan B trial that you have to take into consideration. So we had the postoperative results. We had the pathological report of a patient with a PT2 multifocal disease, which has been resected in Sano, and we have a PN1A, 2 lymph nodes involved, Ki67 of 10%, low proliferation and recount score of 21. So who would recommend chemotherapy at this point of the discussion? Please vote.
It's going to be divided.
So we are getting more conservative. There are much de-escalators in the audience. So nevertheless, if you choose to give chemotherapy, which regimen? Because you know, please vote. Do you need EC paclitaxel or do you need, can you go with 6 times TC? Because in Germany we have a very lively discussion about TC, whether it's sufficient for low to intermediate risk group. Plan B shows in 2,500 patients that it's the case. Yeah, it's equi-effective. So 54% of you are choosing EC paclitaxel and 45% are choosing TC. I think this has been the same in the TAILOR-X trial. I would like to draw your attention that you take into account a 10% risk of long-term toxicity for a patient with an intermediate to good prognosis. I think TC is a very appropriate option in this case. This doesn't work. Sorry. So this would be my last slide, but it doesn't work anymore. Sorry. So what did we do in this patient? Our strategy was not to give chemotherapy, and we had another option for this patient. She was participated in a trial evaluating a CDK4/6 inhibitor in the adjuvant setting. It is a Monarch-E trial, and one of our last patients before the trial was closed. And I think this is appropriate treatment to this patient. She has a long-term risk, which is considerable. She has a 20-year risk of recurrence, even with endocrine treatment, of about 40%, this patient, and we cannot cure this situation with chemotherapy alone or with endocrine therapy alone. So would you give endocrine therapy for 5 years or for 10 years? Hands up, 5 years? 10 years? Yes. I think this patient will benefit from endocrine therapy, and she has a substantial long-term benefit. We will know more about this situation in 2021 when the Eric Sponde study will be published. And I think up to this time, I wish that you will have a very intelligent discussion with your patients in these very difficult cases. Thank you very much.